Welcome, everybody. It's my privilege to welcome you to the 9th Bergin and Garfield Handbook webinar. And this is a joint venture, as most folk will know by now, between SBR, CEPI, and Division 29 of APA. And as said, it's the 9th and it's the penultimate webinar. And there is one final one after this, which will be Louis Castonguay, Wolfgang Lutz, and myself. And we have a tentative date of the 28th of May. Hopefully that will go through the system and will appear in a more formal style. So anyway, today's the 9th, as I said, and it's on personalizing psychotherapy, psychotherapies. And it's a great privilege to welcome Mei Yi Ning from Florida International University and Zach Cohen from University of Arizona. And I think what is particularly sort of special about this is that when Louis, Wolfgang, and I were kind of planning the handbook, personalization was a kind of an area of interest, but would it fly? Would it hold? Would it sort of garner interest? That was 7 years ago when we sat down and planned. And I think it's fair to say that actually it's held its own and it's really captured the imagination. Maybe the evidence is sort of slightly behind, but it's certainly capturing a lot of interest and turning psychological therapies research in a particularly positive direction, in my view, anyway. The other thing which is actually very appealing to this is these are consecutive chapters in the handbook, but actually in separate sections, so to speak, with Mei's in sort of populations in terms of child and youth, and Zach in the domain of sort of new developments, etc. But actually, what is particularly kind of beautiful about this presentation is they have a common theme in terms of the personalization. And I think joining youth, child, adolescence, whatever name you want to give to it, together with adult presentation, I think is very special. So often they get separated and talked about separately. But my aspiration here is that this webinar will actually show the joined upness of psychological therapies research on this particular topic. So that's enough of me, and I'd like to welcome now Mei Yi Ning to present her webinar. So over to you, Mei Yi.
Okay. Thank you very much for that kind introduction. Can you all see my screen? Yes?
Splendid, yes.
So, so I will be talking today about youth psychological interventions and much of what I'll be presenting some highlights from the chapter on psychotherapy for children and adolescents that I wrote with my colleagues, Jessica Schleider, now at Northwestern University, and with my colleagues, Rachel Horn and John Weiss at Harvard University. And at the end, I discussed some current work that my lab and my collaborators are doing that's relevant to increasing precision in the psychological therapies. So our chapter traces the development of the field of youth psychotherapy research from its early focus on efficacy and its evolution towards demonstrating effectiveness in clinical settings, scaling up to increase access to treatment in a population, and then drilling down to meet the needs of the individual youth through personalizing intervention. So that's how I'll structure this talk as well. So efficacy is about figuring out which therapies work well for youth and how well they work. So that there's been an explosion of research on youth psychotherapies in terms of testing them in randomized controlled trials over the past 5 decades. You can see is a huge increase in the number of randomized controlled trials, especially in the last 2 decades. And in terms of identifying evidence-based psychotherapies, that's been a big focus of the field, and researchers have now identified EBPs, evidence-based psychotherapies. It's a mouthful, so I'll say EBPs, for 14 categories of disorders. You can see, them all here. And also for children and adolescents, sometimes the age matters. You can see that for depression, for anxiety, and for disruptive behavior, the reviews have been done separately for children or for early childhood interventions versus school age, versus for adolescents, because it looks like different kinds of approaches may be needed. And here's a quick look at the psychotherapies that have been shown to work well for these disorder categories. So, lots of CBT, and then for depression, IPT as well, DBT, lots of behavioral treatments and family-based treatments. And then ecological-based treatments for substance use and for conduct problems. So now for a look at how well youth psychotherapies work, it seems like they work pretty well on average. You can see the effects of youth psychotherapy represented by the red bars. They overlap substantially with the effects shown by meta-analyses comprising mostly adult psychotherapy trials represented by the blue bars. However, when we when we look at specific disorders, the effects don't always look great. For depression, you can see that for children and adolescents, given by the yellow bars on the left, the effect sizes are a lot smaller compared to those for adults, shown by the orange bars. So you can, this meta-analysis showed that the mean effect for depressed children and adolescents was significantly smaller than for some or all of the adult categories. So youth psychotherapies seem to be efficacious generally, and there are specific psychotherapies identified as well-established or probably efficacious, but then they may not work very well across all of the youth disorder categories, such as depression. So now let's move on to what the data show about their effectiveness in clinically representative conditions. So my collaborator, John Weiss, conducted 2 meta-analyses to test whether EBPs work better than usual care, represented by the green bars on the right. And the included studies involve more clinically representative conditions, including youth who are clinically referred or seeking treatment. The therapists are clinical practitioners who do therapy is part of their day-to-day work, and the treatment is done in clinical service settings. And you can see that in both meta-analyses, the mean treatment effects look much lower compared to when to the broader meta-analyses where trials that are done in research, lab settings are included. So we call this drop in treatment effects when EBPs leave controlled research settings to be implemented in everyday clinical conditions, the implementation cliff. It seems like the research is suggesting that this implementation cliff results from factors such as youth comorbidities that might be very common in clinical practice, but maybe not addressed so well in manualized protocols that are tested in lab-based trials. Sometimes trials might exclude children and adolescents with multiple comorbidities so that they can test the effects of treatment for a single disorder or this disorder category. And then something really important when dealing with youth psychotherapy is that the parents play a big role in terms of bringing the child to the treatment. When the parent gets busy, they can't take off work, or they're dealing with stress or their own mental health problems, and they would not engage as well and bring the child to treatment. I mean, oftentimes, for many kinds of therapy, the parent plays an active role in terms of encouraging the child to work on therapy homework, or even bringing them, for example, somewhere to do an exposure, bringing them to the supermarket to do an exposure. So when the parents are tied up, it does affect engagement in treatment. And then something else that happens in clinical service settings is that there are more time constraints. There might be full caseloads. There might not be enough time allocated for supervision and training as compared to a treatment trial. And so the support of the clinic service organization is really important in terms of adopting and sustaining EBPs. And sometimes that, that's not always the case. And that's why those are some possible reasons for the implementation cliff. So how do we increase youth access to psychotherapy? That's what scaling deals with. In the US, only 20% of youth who need mental health services will get it. And of those, only 20% will receive a full course of treatment. And then existing therapies take on average 16 sessions to complete. But national reimbursement data tells us that the mean number of therapy sessions that youth actually receive is about 4. And finally, most families only get to complete 1 session before they stop treatment. So, I will discuss later, there's, some exciting research showing that single session interventions can bring some benefit, and that might be all some families are going to get is that single session. So we want to be able to, have the family benefit as much as possible from that. So in the US and in many countries, there aren't enough mental health professionals. And even within the country, if the country has enough professionals in general, there are going to be certain areas, potentially rural areas that just may not have enough providers. So dissemination and implementation is a very active area of research in youth psychotherapy. And the efforts in this area can be categorized under, like 3 separate areas. So the first would be whole service initiatives designed to shift the structures underlying youth-directed systems of mental health care. And the best example here is the Improving Access to Psychological Therapies program in the UK. And this draws on existing partnerships with local authorities and service providers. It includes outcome monitoring and using standardized questionnaire. It involves, it's critical. A critical component of this is supporting therapist training in EBPs. And then the second group of efforts involve repackaging EBPs for flexible youth in settings that youth are more likely to spend time. So, there's the clinical settings that we usually think of when we think about therapy, but for children and adolescents, they spend most of their time in school, in primary care settings, in summer camps. So those might actually be better places to reach youth, and parents would, they're already bringing their kids to these places. So if the intervention can be delivered in these other settings, they're going to be more likely to get the treatment and maybe get more treatment. Okay, and then some novel directions for scaling include single session interventions and digital health interventions. So digital health interventions have been around for a while, but with the pandemic in particular, I think that has really catalyzed, like an explosion of research, and practice in this area. Okay. So I was saying earlier that many youth may only receive 1 treatment session. So my co-author Jessica Schleider has looked into whether single session interventions, or SSIs in short, may be able to augment the effects of existing interventions or provide some benefit, which would be better than nothing at all. So she conducted a meta-analysis of single session interventions, and it showed very promising effects for youth with anxiety and conduct problems. Not so great for depression, right? What I was saying earlier is that therapy for depression doesn't seem to work as well compared to other problems, and also compared to therapies for depressed adults. So in terms of a personalizing perspective, we could think of single session interventions as being an important component of step care, right? With many youth who need care, perhaps the ones who have milder symptoms and could benefit from SSIs can be triaged to receive SSIs, so that there are limited resources, the providers can focus on those who have more severe symptoms, who need in-person or one-to-one therapy. So going down to personalizing, how do we maximize treatment benefit for each individual youth? So I think about personalizing interventions or the evidence-based methods to personalize interventions as involving assessing the diagnosis and individual client characteristics, selecting treatments, deciding whether and how to combine them, deciding what problems to target and in what order, and then continually assessing outcomes, processes, and obstacles after treatment has started so that clinical decisions can be made. The treatment can be adjusted based on individual client response. And so I'll talk about some lines of research, because that's really been, I was just talking to Zach yesterday that since he organized the first treatment selection idea lab, there's really been an explosion of research on how to personalized treatments or how to study ways to do that. I mean, obviously therapists have been personalizing treatment forever, but in terms of how to systematically study that, it hasn't been easy. So let me talk about modular therapy. This is one of the ways that EVPs have been repackaged to change the design of standardized manualized treatment protocols. So John Weiss has taken single disorder protocols with a linear session by session structure and repackaged it into a protocol for multiple disorders. So this modular therapy is meant for youth who have conduct problems, anxiety, depression, traumatic stress, or some combination of that. And the therapist, it helps the therapist to just have one protocol that they can use and instructions on how to pull modules addressing each problem area if a child has multiple problems, or if they're finding that they start with one problem and something else is getting in the way of treatment. So this, this kind of protocol can facilitate personalization to the individual, but it can also help in terms of implementation and scaling, because therapists who otherwise might need to learn 4 or 5 manuals can just stick with this one and use this one. So that would really help with training and uptake in clinical settings. So here's an example of how the modular therapy kind of guides therapists to personalize and pull modules from different disorder categories. So if the assessment indicates that depression is the primary problem, then the therapist is directed to start with psychoeducation. And then if the youth is ready, then they move on to other skills in CBT. Yeah, this protocol draws mainly from CBT and behavioral parent training. So problem solving, activity selection, cognitive framing, relaxation. And then if the youth is not ready, then the therapist will determine what is interfering with treatment. If disruptive behavior problems are interfering, then the therapist is guided to use rewards for low motivation, or timeout if there are serious behavior problems, or instructions if there's non-compliance, direct instructions. Or active ignoring if there's attention-seeking behavior. But then if it's anxious thoughts or avoidance that are interfering, then the therapist is guided to use exposure or cognitive reframing modules in order to deal with anxious thoughts. And then if it's trauma exposure or symptoms that are present, then the therapist makes a safety plan and works on the trauma narrative first before going back to depression modules. So John has now conducted several randomized trials, but the first one showed that modular therapy plus progress monitoring did better than usual care, which was what they expected. But what was not necessarily expected was that it also did better than standard evidence-based psychotherapies in like three different manuals addressing, or 3 different manuals addressing 3 different problems. So this looks like an improvement in the design over traditional treatment protocols, but to me, it's unclear what the evidence base behind each of the depression modules is. How much time should a therapist spend on each module before they proceed to the next? Does an individual youth really need all of these modules to benefit from treatment? I mean, a lot of times CBT therapists will kind of call this a toolbox, but kind of like another way to think of this is like we're throwing the whole kitchen sink at the kids and kind of hoping that something is going to work. So, research that would help us select which ones to use first and in which order would be really important, especially when you consider that kids will drop out of treatment after 1 session, after 4 sessions. So really giving them what they need the most first could be really important. So there's another line of research called sequential multiple assignment randomized trials, or SMARTs, that is focused on this idea of which treatment to give someone first. So you can see that the way this is structured, there is one randomization for the youth to receive medication or behavioral intervention. And if they respond, then they just continue with the original treatment, and they get reevaluated to see if they're still doing well. And if they don't respond, then there is another randomization, right? And the options here are to either increase the dose of what they got. So if they got medication, just increase the dose of that. If they got behavioral intervention, just increase the dose. And then the other option is to add the other treatment they didn't get. So if they got medication, it would be to add behavioral intervention to see if they now respond better. If they got behavioral intervention, it would be then to add medication and to see how they do. So this trial conducted by Bill Pelham shows that kids with ADHD actually do the best when they get behavioral intervention first, and then medication is added later on. And this is a really interesting finding, because in this trial, the group that did the worst was the one that got medication first and then added behavioral intervention later. So you can see that the end result is the same. The group that did the best got both treatments. The group that did the worst got both treatments, but then the order really seemed to make a difference. And what Bill and his colleagues thought was that if parents got behavioral intervention first, then they really try to learn those skills very well. And then if that is not enough, they add the medication. But if they got the medication first and that leads to some symptom relief, it might be that they are not as motivated to learn the behavioral intervention skills as well. I mean, that's what they're thinking could be going on. So SMARTs are helpful not just for deciding on what treatments to give and in what order, but also what is the best time point, right? Because therapists has to decide when do I assess and make the evaluation of changing the treatment or increasing the dose. So here's another trial conducted by Meredith Gunlick-Stossel, where they compared a 4-week assessment point to an 8-week assessment point, and they found that the 4-week one was more acceptable and seemed to lead to better outcomes. So another kind of trial that has been a lot of active research going on now is called the micro-randomized trial, or MRTs. In this trial, the individual receives hundreds or even thousands of randomization points. So early on, we just talked about 2 randomization points for the SMART. So this is now thousands or hundreds of randomization points to determine what is most effective in what context. And really, this is most suitable for digital interventions, right? Intervention that is delivered by phone and is automated. So and the person is maybe using this for weeks or months on the phone. So the phone can be delivering a little intervention, and each of those times that the phone delivers the intervention, there can be randomization as to whether they get anything or what is it that you're getting. So here's an example by Rabi and colleagues, the Substance Use Research Assistant app. So these researchers wanted to see what strategies were most effective for engaging adolescents at risk for substance use disorders. And so, this is a phone format. So they compared, giving badges, giving points. You can see that they use an aquarium theme, and it goes from one fish to a full aquarium. So giving points and building this aquarium. There are inspirational messages. There are, memes and so on. And they wanted to test which of these was most effective for engagement. So here are some future directions that my colleagues and I thought that youth psychotherapy could take to move forward. I realized that I'm running out of time, so I'll just quickly go, to the last bit, which is some work that my colleagues and I, my students and I are working on right now, which is, idiographic research. I think psychotherapy research in the past decades have focused so much on group level analyses, but most of the time, treatment is done with the individual, and we're talking about personalizing to the individual. So doing research that really focuses on the individual, I think, is valuable and should complement the the group level designs that are available. So I mentioned depression a couple of times because that's my area of interest. And really, this is a disorder where it seems particularly important to personalize. Depression is often used as the example, right? Where, to meet diagnosis or to meet diagnosis for major depressive disorder, a person needs 5 out of 9 symptoms. They need the 2 core symptoms of feeling sad or hopeless. But then, like they could really have, 2 individuals could really have a different subset of symptoms. They can have entirely different symptoms, where in children, adolescents, symptoms can look even more variable because they could be feeling irritable, not just sad, or they could fail to gain expected weight, right? For children and adolescents, it's not just about weight gain or loss, but their weight is supposed to change. So you have to take that into account. So my colleague, Erin Fisher, has done some work using idiographic network analysis and showed that depression symptoms look pretty heterogeneous across individuals. In this individual, it looks like positive feelings and avoiding people were the strongest prospective predictors of change in the other symptoms. But in this other individual, it's a very different picture. So his work, and work from other researchers seem to suggest that depressive symptoms are not all equal. Some seem to be more important than others. And, the important symptoms, we call them drivers, they seem to differ across individuals as well. And that might be the basis for personalizing. And then this is Jen Frederick. She's a graduate student in my lab, and she has done idiographic analyses of looking at specific effects of CBT modules. Again, we think about CBT as the entire treatment package, but she has conducted studies using interrupted time series models to see whether we can find differences between modules. Or some modules seem to be leading to change and other modules don't seem to do that. And first she did that with 3 participants, and then she repeated that with a different sample of 35 youth participants. And she found that 30 out of the 35 youth had at least one module that was associated with symptom change, but it looks pretty heterogeneous. 14 youth had a decrease in symptoms, 3 had an increase, 13 had either. It looks like behavioral activation was the module most frequently associated with improvement, but you can see here, like all of the modules, had some people, or most of them had people associated with an increase or a decrease. Some had no association at all. And then you can see what this looks like for 3 different participants. For participant 1, it looks like activity selection preceded an improvement in symptoms, but for participant 2, it's getting acquainted. I mean, that's an engagement module, and then learning about depression, that's psychoeducation. So, treatment response was highly heterogeneous. So it looks like for depressed children and adolescents, there are multiple pathways to symptom improvement. She did try to see if we could identify subgroups by the baseline characteristics. Because the thing about idiographic research is that the results only pertain to that individual. You can't really generalize, but when you have a large group of idiographic models, you can maybe start to see if there are patterns. Well, we didn't find patterns, but it might be 30 something. It's just not a large enough sample size in order to look at subgroups. All right. So, so this last bit is again Erin Fisher's work, where based on finding certain driver symptoms, he designed an open trial to compare. I mean, no, sorry, it's an open trial. So it's a single group of adults who received a unified protocol that was personalized to address the driver symptoms first and early in treatment. And they found very promising effects, very large effect sizes compared to a historical benchmark. And the improvement was achieved in a shorter duration. So it seems to be very efficacious and efficient. And then just this last piece is some current work that I'm doing. We're collecting data right now. We're using smartphones to assess symptoms for a month. And then we're also using smartphones to collect data on physical activity, mobility, call and text frequency, and natural language use. Because the thing about doing idiographic research is you need to give the person a lot of surveys for them to answer. And that's a high response burden, especially on kids who spend a lot of their days in school or doing other activities. It's hard to get a good response rate. So being able to get their behaviors as collected by the phones already. Like our phones already collect all these behaviors. So seeing if we can use that to predict depressive symptoms could be something that's really helpful to informing personalized treatment. So thank you very much, everyone. I look forward to the discussion that we're going to have later.
Okay, wonderful, Mei Yi. Many thanks for that. I'll just check to see whether any questions for points of clarification, because I think it would be quite nice to run on into Zach's and then have an open discussion utilizing both presentations. Are there any immediate questions for clarification? No? Okay, well, again, many thanks. And also a belated thanks, I should have acknowledged at the beginning, to your co-authors in the chapter, which was wonderful. So Jessica Slider, Rachel Horn, and of course, John Weiss. Okay, so can we move on now to Zach? So this is based on the chapter that Zach led together with Jamie Delgadillo and Rob DeRubis. Okay, so...
Can you see this okay?
Yes, it's wonderful. Okay.
All right. And
okay,
I have
off you go. Yeah.
25 minutes and 130 slides. So thank you, Mei Yi, for covering so many things so well. I'll post the slides afterwards if anybody's interested. What I'm going to try and get through are kind of 5 big ideas: a summary of the approaches that we use, the types of research that are done with those different approaches, what data we have available to ask these questions, how we evaluate approaches once we have them, and then what are our next steps. And I'll do a lot of that through the lens of modular and digital therapies. As mentioned, this is a chapter written with Rob Rubis and Jamie Delgadillo, both of who are really brilliant and deserve a lot of credit for these ideas. We talk about Gordon Paul all the time. This is the classic quote: what treatment by whom most effective for this individual at that specific problem and under which set of circumstances. What I want to add to the discussion today, I mean, these are sort of the key precision and personalized medicine approaches. Let's not forget about like how treatments work. I think that can be really informative for personalizing and developing precision treatments. And then if you want to get really crazy, ideas about how they work for whom. So, entering into that moderated mediation, mediated moderation. I think those questions are really relevant and are going to be powerful drivers, and we'll talk about them later. So there are many different types of questions that we could ask that would give us information that could be used for personalized or precision approaches. And I want to just kind of highlight those before we dive in. The first is if you have somebody who's clearly struggling with a mental health issue like this man here, pandemic was rough, you could ask, how does treatment help a person? How do you help them get better? And that's a mechanism question, and it's really sort of explanatory. You could also say, if we have different people and we give them the same treatment, so we take these 2 individuals who maybe have are struggling with something and we give them cognitive behavioral therapy, how do they respond differently? Why might one person, given the exact same treatment, deteriorate and get worse, and another person might improve? And those sorts of questions are about moderators, and we're usually doing things related to prediction there. You could also ask, if I had the same person and I gave them different treatments, why might it be that treatment A would help them get better and treatment B would not, or maybe even lead to them getting worse? So now we've got these different types of questions. We could also have different goals of personalized or precision treatment approaches. It's not always just selecting treatment A versus treatment B. And what are those types of goals, right? We might be trying to avoid harm. How do we avoid somebody having a negative side effect? We might be trying to say, how do we know what dosage is going to be optimal for somebody? How do we know the order? And Mei Yi touched on a bunch of these, so I won't belabor the point, but these different approaches require very different data. They require very different statistical analyses. And I think we need to be clear that there is this whole sort of universe of personalized and precision questions, and we have to use the right data and right approach to try and answer them. So how do you guide these different approaches? As part of the chapter, we thought really hard about this, and Jamie was really instrumental in coming up with this idea that there's this sort of like developmental continuum of these approaches. And they start with these intuitive models that are based on sort of your observations or anecdotes. We then try and develop theoretical models that have coherence, and they've got sort of these conceptual models behind them, and those can then be tested. We can move to places where we have data that now can inform it. We've done an RCT and found that, oh, people with this factor seem to do better in this treatment. That aligns with this theory about who would do well in which. And then eventually, we want to move to the space where we have a data-driven model, where it's not just sort of a high-level conceptual finding backed by data, but it's actually a quantitative characterization of the extent to which maybe there are interactions. What if we have multiple factors simultaneously? We really have a quantitative algorithm that can, in a very specific way, generate actionable recommendations. So it's not just people who are employed do better in CBT versus antidepressants, but what is the size of that effect, and how do I use that information in the context of other factors that predict differential response? I want to shout out to Segal for recommending that these things can actually feed into each other. And in the original chapter, we just had them moving unidirectionally, but she made the recommendation that there really there's sort of feedback loops here that are important. And I also want to note that, yeah, there are feedback loops, but I do think that it's a continuum that we want to be moving from left to right. And Roy Perlis, who is one of the sort of really early impactful thinkers in the space of precision medicine, had a great quote where he said, you want artisanal bread, not artisanal medicine, right? So you really want something that's reproducible, that's evidence-based, that's trainable, that's disseminable. You don't want it to be sort of like bespoke, anecdotal, intuitive. And I think that's an important thing to emphasize, because it's important to attend to clinical judgment and expertise, but we need to also have evidence and structure and reproducibility to drive that. So what is a theory-based approach? I'll give you a very quick example. In our digital therapy, we have these animation that describe clinical techniques, and we're doing a technique like cognitive restructuring, and we actually explain it with different animation for people who have social anxiety versus PTSD versus panic disorder versus GAD. It's the same concept, but based on assessments we do at the beginning, we tailor the stimuli, the explanation, sort of nuances of how we explain it based on what's going to be most resonant to that person based on their sort of unique presentation. We haven't done any RCT to show that doing it this way is better than giving everybody the same, more general thing. We haven't shown that if you give somebody with panic disorder, the panic disorder explanation for cognitive restructuring, that will lead to better outcomes than giving the panic disorder person the social anxiety explanation, right? So it's not really data informed yet, but it's theoretical, it's sensible. I think it's a very good place to start in a rational way to approach things in the absence of data that can inform it. We want to move towards things that are data informed, though. And I really want to emphasize that wherever possible, we want to do this. Now, why is that, right? So when we were trying to say which of the modules, which of these different clinical techniques should we include in our digital therapy, we had to triage. You can't include every therapy under the sun. You can't do the kitchen sink. There's not enough time. People have limited attention spans. And so we were trying to pick for depression, which are the ones that we want to include. And from the sort of library that we had, we were like, oh, mindfulness, that's probably not going to be the most important one. That was our sort of our clinical bias. And so we were going to say, okay, let's kick out mindfulness. But Ed Watkins did a fractional factorial study where he randomized 900 people to get 50% chance of getting one of these 7 modules, right? And so what you could then do is you could say, okay, well, 450 of them got the activity scheduling module, which is behavior activation, and another 450 didn't. So they're balanced on everything else. And you can look to say, what is the actual sort of causal estimate of that module? And you could then do it for all 7 of the modules using all the individuals. So we've got strong power to answer this question. You didn't have to run 7 designs. This is one of the things that Mai alluded to. And when we looked at the evidence, to our great surprise, it wasn't behavior activation, it wasn't cognitive restructuring, it wasn't the problem-solving module, it was the mindfulness absorption module that was the most effective one. So if we had used our sort of clinical intuition, we would have thrown out the module that the evidence said from 900 people was the most effective. So I just want to emphasize, when you're sort of starting to do personalization, good to rely on clinical intuition, but seek data. And so then we responded to that and included the mindfulness module in our intervention. So we have all of these different clinical techniques drawn from evidence-based interventions. We worked with intervention development, leading experts to have all of these. Now we end up with 30 different treatment modules: exposure, self-compassion, cognitive restructuring. You would sort of recognize all of these. How do we determine who gets which module, right? Our starting point was, okay, let's think about the patterns of comorbidity that exist and sort of sensible sort of clinical combinations. And so what we did to start was we made packages that targeted those really important and frequent patterns of comorbidity for the population that we were working in, which is college students. And we had an adaptive baseline assessment that can, trying to minimize participant measurement burden, get you a sense of who is above threshold on these different areas. And so we do that at baseline. And then based on that, we also ask people, okay, it seems like you're above threshold on depression and PTSD. Which of those is most distressing to you? Which do you care most about improving? So we're combining this sort of purely data-driven or data-informed approach with shared decision-making and respecting the agency of the individual. And I think that's important in these precision data-driven approaches. So we combine that information and based on that, they get allocated to one of these packages. So now we've got, I think at this point, close to 400 people who have started one of these digital therapy packages. They're all these sort of disorder or comorbidity-based packages. I'll talk about in a little bit sort of what we're starting to learn from them. I want to make one more pitch as to why data-informed is better than theory-informed. For all of my clinical training, it was common knowledge that in the context of CBT for depression, you want to start with behavioral activation, and then you go to cognitive restructuring, right? That's the way that it was laid out in the original manuals, the idea being that, okay, you can get people who are maybe anhedonic or withdrawn, you can get them activated, engaged, and then you have more fodder. You're, getting them exposed to some potentially reinforcing stimuli, right? This is always what we've learned. So when we built the modules, we said, okay, we're going to use that clinical knowledge to say behavioral activation should come first, cognitive restructuring second. But a few years ago, this large randomized 2,300 person randomized clinical trial came out that basically randomized people to either get cognitive restructuring first and then behavioral activation, or behavior activation and then cognitive restructuring first. These were digital therapy modules. And lo and behold, on average, it didn't matter. So it might matter for some people, but at least on average, there's actually no difference. So we didn't have to be constrained by that clinical knowledge. Okay, hopefully I've made the point that those data-informed approaches are better. We also looked at things like, okay, there's all this evidence for the fact that if you treat sleep in comorbid depression or in comorbid PTSD trauma, that leads to improvement in depression and PTSD. And so we added a module for that comorbidity, and there's evidence that if you do it early in treatment, that's better. So we're using data from the literature, right? Might be an alternative ordering, but we won't worry about that now. I'm on slide 47. I need to speed up. So there are other types of personalization that we do within it, right? It's not just which module. Sometimes you have different techniques within a module. So for people with sleep problems, you can have people with primary insomnia, terminal insomnia, or people who wake up during the middle of the night. And those different chronotypes actually need very different clinical interventions, right? If you have somebody who's having trouble falling asleep, you're not going to do the same thing as somebody who has trouble waking up in the morning too early. And so what we have to do is we have to do these assessments. Right now, we have to do a sleep tracker, and then based on that, we learn what your chronotype is and your sleep efficiency, and that informs this personalization. What we'd like to do, as Mai already mentioned, maybe we can start to use apps or digital phenotyping, and we can passively sense that. So we have studies where we're starting to use data from smartphones and watches to try and sense some of these things, get more accurate objective data, but also decrease measurement burden while supporting precision treatment. Okay, what we want to do is data-driven approaches, which I introduced but haven't given any examples of yet. And the idea there would be, okay, we have an actual predictive statistical algorithm that takes information about the individual and generates a concrete recommendation. And that might be in the context of a modular therapy where it then selects and orders specific modules for the individual. Now, this work really grew out of some early work that was at a much higher level of just who needs which treatment. And that might be a question of high versus low intensity, or it might be a question like, okay, we've got different packages like cognitive therapy or antidepressant medication. So this is from our chapter, and it basically breaks down all the different types of personalization that you can do and ways in which they can differ along these three axes: how structured it is, what the level of intervention is, and when you're making the personalization decision. So that example I just gave was, okay, we might be able to identify patient prototypes where they're going to be pliant in that they respond to an active intervention more than they do a placebo. They respond to a stronger versus a weaker more. But there might be actually sort of pliant subtypes where one individual might respond really well on the left here to antidepressant medication, so this percent improvement. And if they get antidepressant medication, they're going to do really well. They get cognitive therapy, not very well. And then you might have another pliant type who would respond really well to cognitive therapy, but not antidepressants, despite the fact that they're equally effective. So if those people really exist, wouldn't it be great if we could identify them so that we're not doing trial and error treatment allocation or treatment selection? And so that idea would be, in the real world, we often don't really have good ideas about who's going to respond best to which equally effective evidence-based treatment. And so we do trial and error. And what we'd like to do is to do that right the first time. And so the personalized advantage index approach is something that I developed, our lab developed in graduate school with Robert Rubis. And it does what I just described, developing a statistical predictive model that can then help inform that decision and contribute to a shared decision-making process. And in the original demonstration of that, we showed using randomized clinical trial data and sort of cross-validation that if you had allocated people to the randomized intervention, because some of these people randomly got the one that was predicted to be optimal for them, that they had better outcomes than those who got the non-optimal intervention, despite them being equally effective on average. And there was also a bigger benefit if you looked in the subset for whom stronger recommendations were made, right? So the prediction or the recommendation is not necessarily just binary, you do better in CBT than antidepressants or vice versa. It's also how much better would you be expected to do? And that information matters too. In the time since that original publication, there have been dozens and dozens of studies that have used this or similar approaches. The vast majority of them were reanalysis of retrospective data. I did that work for a decade and got a little bit frustrated with it. And so a lot of what I'll tell you about next is how can we do other things? So one of the issues is that these retrospective data sets are really small. It's hard to run these studies. And so we just don't have big enough sample sizes to do a lot of this modeling. You also end up with the data that they decided to collect 10, 15, 20 years ago. So there are other types of experimental approaches. Mai spoke to some of those, so I won't belabor the point, but you can have sort of classic additive and dismantling studies, you can do sequencing or all these different smart designs. But even those, the data aren't really easy to get. And so I think to move precision and personalized treatment forward, we also want to think about how can we leverage non-experimental data. So one way we can do that is through quasi-experimental approaches. What are those? Things like propensity score matching, discontinuity analysis. What's propensity score matching and how much confidence should we have in it? Well, you can think about it as like, okay, we've got a whole bunch of people who happen to receive one versus the other treatment. And we try and identify people who look the same on as many factors as we have at baseline that we think are important. Now, that's a maybe sensible approach, but I don't have a ton of confidence in it because it's only as good as the data that you have. So here's an example. Each of these two individuals, male, born in 1948, raised in the UK, married twice, live in a castle, and they're wealthy and famous. They would be sort of those people who we would say would be sort of these like kind of synthetic twins in a propensity score matching approach. They are not the same people, right? Discontinuity analysis is, I think, a better way to do it. So you can have these for a variety of reasons, people who end up receiving different treatment based on sort of a semi-arbitrary decision point. So in the digital therapy that I described, people will end up in one package versus the other based on being above or below threshold on different symptom domains. And so if you imagine that these people, one person might be 1 point above the depression threshold, one person might be 1 point below, one person might be 1 point above on sleep, 1 point below, right? And then the same in anxiety. And so these people really have the exact same scores, right? 1 point on any of these things is noise. But because of that sort of arbitrary place they landed on that continuous decision boundary, this person's going to get a very different intervention. And we could look at those and compare their outcomes and sort of assume that they were almost randomized to those two treatments. And so what that'll look like is, well, this person ended up in worry and sleep package. This person ended up in worry and depression. And they got a lot of the same modules, but maybe they got them at different times. Or maybe they got different modules in some places. And so you could look to say, well, this person started with tackling triggers. This person started with getting going, behavioral activation. How does this change their anhedonia, right? And we might be able to sort of start to infer things analytically about how specific modules work in a way that, you know, approximates having randomized people to these two modules. And then we can do modeling. And we've talked about modeling in the package sense. I think there are a lot of limitations to what you can do with a pure modeling approach, or at least barriers. And especially when we're trying to understand how treatment works because of the nature of psychological therapies, both when they're packages and maybe a little bit fewer barriers when they're these more modular approaches. And so if you ask for sort of my bet, I would say that modular interventions are going to be the most promising, one of the most promising places to pursue this work. So what we're trying to do is select treatments. You can have something that combines them. I only have 3 minutes left, so I'm going to rush through this. We're doing that work at UCLA in a system where we combine sort of all three of those levels. We developed this digital therapy that I already told you about. And it has a bunch of very cool features. So I think measurement, right? How can measurement support this sort of work? Well, I think too often we assume that this person got CBT and getting CBT is getting CBT is getting CBT, and we compare people who got it versus didn't, right? But what happens in therapy is actually really variable from person to person, therapist to therapist. So I think we need to do a better job of quantifying what actually happens. Now that's hard to do in face-to-face therapy because you usually have to do something like rating tapes and it's labor intensive. In digital therapies, you can actually get a lot, I think, more traction in ways that are a little bit automated. And we broke this down into measuring what is delivered as part of the therapy. So for example, a skill that's taught, what does the patient receive, what's learned, and then how do they apply that in their daily lives? And so if you think about that, we've got all these different sources of data, and maybe in the context of a digital therapy, you have process data, like how does their rumination or avoidance change? You've got the classic symptom assessments. You've got engagement. Are they doing the, coming to the sessions, doing the modules? technique use, how often are they doing behavioral experiments. And if you imagine having all those different data types, potentially assessed with a digital therapy toolbox where they track their activity and mood, and you could say, okay, think like a clinician. What are the different ways that you know that therapy is working when you're working with a client? And what are the different ways that you know how that it's working, right? So here's some real data from a patient who did the prolonged exposure module, who had clinically significant PTSD. And you can see from the app, this is lightly anonymized, they identify the memory that they're working on. They identify what they're worried will happen if they engage with it, their rating of how certain they are that it's going to happen, how distressed they expect to be. Then they do the guided audio for prolonged exposure. Afterwards, they reflect, did their greatest fear happen? They say no. How do you know that it didn't happen? Each time I revisited it, I felt less and less anger. What did you learn from the exercise? My fear was caused by a buildup of emotions, and now I know that I can handle thinking about the memory without losing control. And then what's their expectation that the feared outcome would happen if they engage with the memory again and it's gone down to a 50? So if you look at that, if you know how exposure for PTSD works, like that is classic, that's what you expect to see. Now imagine having this for hundreds and hundreds of people and being to really apply like quantitative analyses to this sort of process data. And my argument is that maybe that could get us to a point where we can gain more traction on how treatment's working and for whom it's working to guide personalization. Can I take 2 more minutes, Michael?
Yes. Yeah.
Okay, 2 more minutes. Here's another example participant where we have the data. This is a participant with PTSD. They did 2 modules, behavioral activation and cognitive restructuring, not big improvement in their PTSD symptoms. Then they engaged in the prolonged exposure module, huge drop after completing that. We could look at the coach's note. The participant successfully completed exposures, improved her strength to herself. I believe the participant left the session feeling safe and supported. So we could start to actually look at the timing of symptom change with these data from all these different angles, and start to understand how your clients are doing. We could have knowledge probes, asking the client if they understand things. We could have objective ones where we could provide corrective feedback based on whether or not they actually answer questions about the different techniques right. Yeah. And final part is, in addition to those sorts of ecological momentary data or intensive longitudinal data, we could then also layer on top of that things like digital phenotyping and EMA. So we're doing that in a pilot study, aiming to collect data on 140 people who are engaging in the digital therapy that I just described and tracking them across that. We're giving them all Apple Watches. And then we have to figure out, once we have that information, how do we translate it? There's all sorts of different ways. It's important to do cross-validation. And what I want to highlight for my last thing is Jamie Delgadillo, one of really the people doing the best work in this area, led a actual randomized clinical trial of a decision support tool that was developed with a data-driven approach, randomized at the site level. So some people got their decision of should they get high versus low intensity therapy informed by that predictive model, and other people had it with allocation as usual, which is sort of clinician judgment, best practices. And he was able to show that that led to improvements in outcomes. And this is like groundbreaking, amazing landmark stuff that shows that actually using these data-driven approaches can, in real world terms, improve patient outcomes. And what's next is, how do we get those actually into the clinic? Now that we know that we have, or are starting to have approaches that work, and I want to highlight the fantastic work of Ann-Katrine Diessenhofer, who really led this big effort to summarize what we know, what are sort of the best practices, and what are the things that we need to be working on next to take these approaches and actually implement them in the clinic. So if you're interested in that, I would check this out. Okay, thank you for letting me go over.
Okay, wonderful. Many thanks to you, Zach. And I'm glad you got Ann-Katrine's paper in there. It's wonderful. Okay, we've got 15 minutes or so for questions. So any takers on questions? How about if I just start off, maybe for Mei Yi, but also for Zach. Jamie and I were discussing earlier in the week about modularization, sequencing, etc., which seems to be a feature of much of this work. And the question really is, how do you deal with early response, in the sense that we know that early response is a feature? So in a sense, if you get a good response from a range of treatments, how do you know that that's not early response rather than actually specifically to that particular module? Mei Yi, do you want to kind of take that one for starters? And I'm sure Zach will add in.
That's a great question. I mean, just thinking about the ideographic models that my student Jennifer Frederick have been looking at with specific module effects. And by the way, those are using data from John Wise's match trials across multiple trials. One thing we can see from those data are that the modules that seem to be associated with improvement don't always occur early. So across the whole group, we're not seeing that they're always the early modules. You know, they can come up throughout the therapy. But for that particular, like for each particular individual, how do we know that if they happen to have an early response, was it due to that module, or was it due to, like the timing? I'm thinking about some of the quasi-experimental designs that Zach talked about. If we can match people based on either their scores or, right, I think for the was it discontinuity analysis, like that's a way to match two different people who seem to have those similar scores, but then they got a different module to see whether they both had an early response, or did they have a response to the same module that may have been given at a different time. I mean, you would need, right, a lot of participants to be able to make these comparisons, but I think that's a start.
Okay, thanks. Zach, do you want to add anything?
That I agree with everything that Mai said. I didn't hear the full question because I was trying to answer one of the questions in the chat, but I think what I can add on to what I did hear was some of those factorial designs, when the intervention is truly modular in the Tirapita and Weiss definition, where there is no dependency, so everything can go in any order, which is how we built Rainfrog, then in those factorial designs, you can randomize the order. So you get determined to have some subset of the modules, but it's not like behavioral activation always comes first. It could show up in any place. And so I think that can start to generate evidence about what you're asking.
Sure. Okay, thanks. Okay, any questions? Anyone have any questions? Oh, Wolfgang?
Yeah, I have a question. I really enjoyed both of your talks. It's really wonderful and really cutting edge developments. I have a question more on the ideographic approach Mai Ji was presenting, and the leading symptoms you were selecting based on network models. And maybe this belongs also a little bit to the sequencing idea from Zach. I was just wondering, we all know with the network approach, what's the central, if different groups do different analysis, then you come to different networks in a way and to different symptoms. And there is something what's often called the fat finger thing, so that if you work on one symptom, it might have impact on all the others. And I was just wondering if we don't have something similar, not only when you go on an ideographic level, but if you also go on the sequencing level, that it doesn't maybe matter too much with which module you potentially start. You might have that impact on the broader network of symptoms. I was just wondering what your thoughts and ideas are about this. Yeah. I don't know whoever wants to start first.
Well, he posed it to you, so I'll let you take first swing if you want it.
Let me just make sure I understood the question correctly. Was the question about because the symptoms are all in the network and they're all connected, it doesn't matter which one you target first. If you target one,
Yeah,
then everything else is going to go down.
Exactly. I mean, if you use like central scores or however you want to define the main important symptom, there are different methods to use in network analysis. I mean, there was recently a paper by Laura Pringman's group where we have like 5 or 6 or maybe over 10 groups defined the network, and they all came with a little bit different kind of leading symptoms. So I was just, and there is probably something happening, which is if you start at one place, it has an impact to other areas or other symptoms. And I was just wondering how you plan to deal with this kind of problem.
I'll take a swing if I may. So I'm a big fan of Laura and a lot of the work going on in that space. So she's fantastic in many ways, one of which is that she's so critical of this area in which she really has done so much innovation. There's one issue, which is, are these things reliable, period? What is the extent to which the researchers, semi-arbitrary analytic decisions would lead to very different models? So there are all those questions, and I think those are very important. Let's imagine that we got to a place where we had reliable models and that they were sort of reproducible in the sense that it wasn't idiosyncratic to the analytic technique or the researcher, that there was some, core finding that was true. And I think if we had those, that's what I want to think about driving towards in the context of doing it and I guess what I'm saying is I think we're going to get there by doing it in a way that is theory informed, right? So not just assessing a bunch of symptoms, throwing them into the latest network modeling approach, looking at the network that comes out of it, and then using that to inform treatment. I think we have to think, well, clinically, are we observing things that might be able to be captured by novel analytic approaches? So somebody who comes in and they really experience a lot of shame, and then when they experience shame, that leads to avoidance in their lives. So think about classic case conceptualization. Can we take things like case conceptualization and the clinical theory and then actually develop rigorous empirical evidence supporting those observations and models? And if we could do that, and if there are differences where, for some people, sleep is a huge factor and it leads to differences in irritation and memory, and that leads to something else. And for other people, it's not that, right? It's something else. Can we develop rigorous models that could identify those differences? And if those differences are meaningfully related to how we should approach treatment, that's, I think, how we're going to get there.
Thank you, Zach. I think I definitely know that there are limitations with the network models. And I think it's an active area of research in terms of developing the methodology. I think maybe a hopeful way to see things. I think most people maybe have a couple of symptoms that are central or important, right? I guess I am considering, I think it's considering, I think it's probable that some symptoms may be more important than others, at least for some people. I'm not sure that we, and maybe there's this model or this method that is better at identifying one of those symptoms from the important group, and maybe another one is better at identifying another one. And I guess I'm thinking that if any one person has multiple ways that they can get better, If they have multiple driving symptoms, there are multiple strategies you can use to help them. Not every single strategy, but there are some selected ones. Then that's a win. It means that you can give this, or you can give this, or you can give this, and it can help them. But yeah, I mean, definitely, you know, like the methods work needs to continue. And I mean, I guess I was especially excited about Aaron Fisher's findings because he went beyond the networks and used that to personalize the unified protocol, and the effects look good. I mean, there's no RCT, you know, it would be better if there were an RCT showing that the personalized version is better than the standardized version. Like that would be an even better test that there is something useful about those networks, right? The networks may not be 100% accurate in identifying like the most central symptom, but it may be selected something important to target early.
Excellent.
Okay,
Yeah.
many thanks. Can we just take one last question? Can I ask Catherine Davis to unmute herself and ask the question that she's put on the chat? Catherine, can you do that?
Yeah, certainly. Thank you both for such wonderful presentations. I'm wondering about, it seems to me that the bulk of these models took into account pre-treatment characteristics, even in terms of things like matching or, you know, client variables. And I'm wondering if there have been methods or models that looked at not so much process variables, but maybe routine outcome trajectories or symptom trajectories, and how that would inform within patient a precise model.
Yeah, so great question, great suggestion, and yes, definitely. I think the whole literature on just-in-time adaptive interventions is focused on that sort of thing, where you are doing ongoing measurement, and that tells you what to do, when to do it, and that, as you point out, could be symptom response, it could be engagement, risk of dropout, it could be development of side effects, it could be early response. There's the whole sudden gains literature. There's all sorts of, I think, high likelihood things that you could monitor during the course of treatment that would then inform that sort of responsive treatment adjustment.
Last word to Mei Yi.
So I think the just-in-time adaptive interventions, my understanding is that the evidence base for that needs to be built, you know, at least in part on the MRTs, the micro-randomized trials, because those trials allow you to keep giving little interventions. I mean, and usually these are done in the context of a digital therapy, because then you can keep randomizing every day. There can be, or you know, multiple times a day, there can be a time point where the program is going to randomize the person to receive a little prompt to do an activity as part of activity scheduling, or to receive a prompt to do a, you know, to review their thoughts and identify anything that they need to change. So yeah, so just-in-time adaptive interventions and the micro-randomized trials. I mean, you know, even just going back to modular therapies or routine outcome monitoring, I know there's that work involves routinely monitoring the symptoms and any treatment obstacles, and then using that to make decisions about what should come next. I mean, my understanding of that work is that it's part of the trial, but those trials don't, you know, I mean, the control groups either don't have the routine outcome monitoring or they have it. They're not really able to, they're not designed to test whether each decision that, you know, that they selected this option versus another one, whether that was effective. And yeah, and I think that's how and why the MRTs are coming in, but then MRTs can only be really realistically be done with digital interventions.
Oh, just 30 seconds. In Michelle Krask and Kate Walitsky-Taylor's large 1,000-person alacrity trial, it's a 2x2, and one of the randomizations that people get allocated to is just-in-time adaptive intervention versus not. And the decision there is ongoing monitoring of symptom worsening, including suicidality, and it moves you up and down between the tiers. So if you're in the digital therapy tier and you develop suicidality, for example, if you're in the just-in-time adaptive intervention group, then you would get moved up to tier 3. And so that is one that is a bigger decision that isn't a micro-randomized trial. I agree with what Mai is saying, but there are some that are ongoing that are looking at bigger questions.
Okay, wonderful. Huge thanks to both of you, Mai and to Zach. And kind of remind folk here that Juan Cruz has kind of reminded everybody that all these webinars are available on the SBR YouTube. And hopefully we will see yourselves and others on the 28th of May for the final bash. You can bring drinks, we'll have fireworks, and hopefully it'll all go well. Anyway, lovely to see you all, and many thanks.
Thanks for organizing this.
Oh, it's a privilege.